evening and welcome to NRAS Facebook Live. I'm Claire Jacklin, I'm Chief Exec of the National Rheumatoid Arthritis Society, and I'm really delighted to be joined here this evening by Sarah Leyland from the Royal Osteoporosis Society. We thought this was going to be a great topic for us to cover, which we haven't covered in the past, I'm sad to say, because we do get so many queries about the link between rheumatoid arthritis, inflammatory arthritis, and of course osteoporosis. So welcome, Sarah, and thank you so much for giving up your evening to spend with us for about 30 minutes, 40 minutes this evening. Would you like to introduce yourself?
Yes, thank you very much, Claire. I'm delighted to be with you tonight. And yes, exploring the relationship between these two conditions. And there've been fantastic questions coming in, so I can see we've got a very interested audience. So so I'm a specialist nurse, an osteoporosis specialist nurse. I work with the Royal Osteoporosis Society, and I work there across a number of projects as a clinical advisor.
Great, thank you so much. And we have had many questions pre-submitted, so just to let you know, those who are watching live this evening, do please use the chat to comment and talk about what you're hearing. But we won't be able to take live questions this evening, but we hope that we'll be able to cover many of your queries as we go through. And first of all, Sarah, you've got a short presentation about what our topic is this evening, which of course will stimulate probably some questions from myself as well. But so over to you, Sarah, for your presentation.
Thank you. So yes, we're going to start off with a few slides, 10 minutes or so, and then we can go on to take your questions. Okay, so I'm sharing my screen. Perhaps you could just tell me, Claire, if it's all looking okay.
It's perfect. I can see it. No problem at all.
Great. Okay, so I'm going to talk to you about osteoporosis, bone health, and rheumatoid arthritis, and hopefully looking at risks, because there are some risks for your bones with rheumatoid arthritis, but also opportunities and how you can work to promote good bone health. So about osteoporosis and fragility fractures, that's the word that's used to describe the broken bones, the fractures that are the end result often of osteoporosis and cause the problems for people in terms of pain and symptoms. I'm going to talk about the link with rheumatoid arthritis. And then I'm going to move on to talk a bit about getting your bones checked and who needs to do that and what's the next steps. And then finally, I'm going to look a bit more widely at how you can help your own bones, really. And that's in terms of lifestyle, things you can do, but also talk a bit about medications which can strengthen bones, but also the importance of medications for managing rheumatoid arthritis and how that in itself will help your bone health. So let's start with a few facts about osteoporosis. It's a medical condition when bones lose strength and they break more easily. And it's these broken bones or fractures, as I say, they're called fragility fractures in the medical world, that cause the pain and the disability associated with osteoporosis. And then we have these spinal fractures, not broken bones in the way we think of broken bones, sort of squashed, compressed bones in the back that can cause pain, but also in the long term can cause height loss and curvature of the spine. Important to say that there is a diagnosis of osteoporosis made from something called a bone density scan. So if your bone density is lower, quite a bit lower than the average adult, this is a really important risk factor for fracture. It tells us that your bones are likely to be less strong. And if your bone density is at a certain level, then you are diagnosed with osteoporosis. It's got a very specific meaning there. But I think also just an important fact to just stress is that you only get the pain, the loss of height, the curvature and the symptoms if you've got broken bones. So having low bone density doesn't give you any symptoms at all. And I think sometimes that's not quite understood. So some facts there about osteoporosis, and let's just talk a little bit about what I'm describing as the living skeleton. So it's really important to understand that your skeleton isn't a sort of dead, inert thing sitting inside. It's constantly changing, and the old bone that's inside, if you were able to look inside your bone, you'd see these struts, the scaffolding, particularly in the ends of your bones and in your spine. And then on the outside of the bone, there's a kind of a shell, a hard shell. And this is constantly changing. There are special little cells wearing away at nibbling away at these struts and taking out little chunks of bone and then refilling them. And that's a normal, healthy thing that keeps your skeleton, your bone tissue strong. Now, with osteoporosis, this seems to get out of balance, and more bone is being worn away than is being rebuilt. And then as a result, we get the thinning of those struts inside the bone and a thinning of that cortical shell. So that in itself is starting to affect the strength of the bone. But the really important thing that can happen is that the whole structure inside the bone can break down, and that's when bones become really much weaker. Now, these at the bottom are examples of the typical kind of fractures, broken bones that you get with osteoporosis. So they can really, these broken bones can happen anywhere apart from the skull and the fingers and toes. We don't think those are related, but there are common sites. So we see fractures quite often in the wrist, in the back, as I've described, the squashing down of the spinal bones, but we also see fractures in the hip. And when we talk about a hip fracture, a broken hip, we actually mean what's the top bit, the neck of your thigh bone, and that's vulnerable too. So these are common sites. So really important to understand that osteoporosis, meaning bones have lost strength and are more likely have a tendency to break more easily. So that's really osteoporosis. So I hope that set the scene for you. And really important to say that broken bones with osteoporosis do have a huge impact. I mean, sometimes people think, well, a broken bone, what's the big deal? You know, it gets better. But we know that people fall, they break bones easily. That in itself is traumatic. They end up in hospital. They often stay for a long time. They don't go back to their own home. This is particularly because it affects older people. And then we know that although the bones in the back heal, they don't go back to the shape they were. So people can end up with a curved spine, a loss of height, and that can have psychological implications as well as physical ones. So a huge impact, not for everyone, but for some people. So it's important that we think about how we can reduce the chance of these fractures happening. We know that it affects a lot of people. These broken bones affect 1 in 2 women and 1 in 5 men in older age. So it is a common problem. I thought I'd just say a quick thing here at this point about the difference between osteoporosis and osteoarthritis, because I think there's a common misunderstanding. So just jump in here with a couple of pointers. So osteoarthritis is when the joints are painful or stiff, and that's often because of a sort of overgrowth of bone, or a change to the joints or the spaces between the bones, spaces around the joints. So it's a joint problem. Osteoporosis is a condition when the bones themselves lose strength and break more easily. And as I said, it's the fractures, the broken bones that cause the pain and the disability. The changes are only going on inside the bone unless it breaks with osteoporosis. So they're different conditions. Some people have both. It can cause the same sort of symptoms. So you can get pain, you can get curvature of the spine with osteoarthritis as well as osteoporosis, but they are different conditions. So I just thought I'd jump in with that. And of course, we're going to move on to rheumatoid arthritis, which is different again. But I hope that's helpful. So what puts you at risk? You know, what causes osteoporosis? Well, the biggest thing is old age, actually, that imbalance in the bone building and the bone wearing away. That it all seems to happen, and things get a bit out of balance when we're older, unfortunately. There's a genetic input, so 80% of our bone strength is probably down to our genes, but there's 20% of we can do something about, so lifestyle is important. There's something around gender, because women start off with smaller bones. They lose bone more rapidly around the time of the menopause when their estrogen levels drop, and they do live longer. So as the process goes on, they're more likely to end up with fractures. A very important risk factor for future fracture is having had one already. So that's why it's very important, if you do break a bone easily, to go and get your bones assessed and think about a treatment for your bones, because one fracture does lead to another. It's a very good sign, if you break a bone easily, that your bones aren't as strong as they should be. There are these risk factors you can change. So if you're very low in body weight, and some conditions like anorexia nervosa are affected with associated with osteoporosis. We know immobility. So if you're not using your bones, then they get weaker. Smoking, alcohol, and actually people who unfortunately are falling over quite a bit are obviously at risk. Now, I've highlighted some of the things that I think are most important to you, our audience tonight. So these are things that relate very much to rheumatoid arthritis. So there may be immobility problems if you've got a severe condition, and you may very well be on a medication such as a steroid that we know unfortunately is not good for bones and can make bones weaker. And the other thing that's really important to understand is that there's something about inflammatory conditions like rheumatoid arthritis that actually seems to affect bone strength. So there's something going on just because you have rheumatoid arthritis that may have an effect on your bones. There's lots of other conditions associated and medications, which I won't go into now because I don't think they're relevant, but hopefully you can pick up here some of the other conditions and treatments that may be associated. So how do you know if your bones have lost strength? Well, we don't have a perfect test, I would say that. So although many of you will have heard of bone density scanning, which is very useful, particularly when we're trying to decide if you need to take a bone strengthening drug. And we do know that if you go and have a bone density scan, the lower your bone density, the greater your risk of breaking a bone. And as I said, osteoporosis is diagnosed on a scan if, in fact, your bone density is lower than the average adult. But it is important to say that bone density is only one part of bone strength. So it's the bit we can measure, but it's not a perfect measure. And so we now do something, sorry for all these words, but we do something in the medical field called fracture risk assessment. So what that means, you go along and they look at all your risk factors, all the things that research has shown may be affecting your bone strength, and they piece all those together and they build up a picture of your fracture risk in the next 10 years. So this is how they kind of work out what your bone strength is likely to be like in order to decide if you need a drug treatment. And just to say also that in terms of tests and scans and investigations, it's x-rays that still are the best way of looking to see if you've actually had a fracture. So an x-ray of the spine to pick up a spinal fracture. So I hope that's giving you a little bit of a background in terms of how you know whether your bones have lost strength. Now, we've got a range of drug treatments for osteoporosis. I won't go into them in a lot of detail, but I noticed some of the questions are relating to these, so we could pick it up later. We've got drugs called bisphosphonates, alendronate, zoledronate are examples of those, but we've got other treatments too: denosumab, teriparatide, strontium malate, HRT, and romosozumab. And who gets them? Well, they will give it to you, as I say, if you've got a high fracture risk. It's usually in the people who are over 50, because we know, as I say, that bone in itself just tends to get a lot less strong. The structure breaks down as we get older. They sometimes give treatments to younger people who've got very strong risk factors. So if they're on a high steroid dose, they're breaking bones perhaps, or they've got, they're continuing to lose bone density, they may give you an osteoporosis drug, but not so often. Perhaps just a little bit more here. What are the steps before you need a medication? Well, when people say, do I really need a bone density scan? Not always, because I think if you're older and you've got this high fracture risk because you're on a steroid dose that you're going to stay on for quite a long time, you're over 70 perhaps, you're on a higher dose, and particularly if you're starting to break bones, then they may treat you without doing lots of bone density scanning and so on. I thought I'd just make that point. Otherwise, when you get to around the age of 50, that's the time, particularly after the menopause for women, when they do a kind of overall bone assessment almost routinely if you've got rheumatoid arthritis, I would think, and then they would look at often your bone density as part of that. As I say, if you're younger, you would need to be referred to a specialist, and occasionally they would use a treatment if you're on the high dose steroids, but they are quite cautious about using long-term medications, particularly in younger people. So that's that. Let's move on to what you can do yourself. So there's some positive messages here, which I hope you feel you can take away something you can do. So healthy, balanced eating, a calcium-rich diet with adequate protein, that's a really good starting point. If you can be doing exercise, then using your bones is great. And there are specific types of exercise that are best, what we call weight bearing, so standing with a bit of impact behind that. And also working on particularly on your muscles, muscle resistance exercise. Those are the best things. Keeping an appropriate body weight, so not getting underweight, not smoking, not having excessive amounts of alcohol, and getting enough vitamin D. So that vitamin D helps you to absorb calcium, and we get that from sunlight during the summer, but probably need to consider a supplement during the winter. And the other thing as we get much older is to think about balance and muscle strength exercise to prevent falls. So it's not only about exercise for bone strength, it's about exercise to reduce your risk of falling as you're older. So lots of positive things. I hope there's something here you can take away. And then finally, what are the other opportunities? Well, I think one of the most important messages is getting your rheumatoid arthritis managed well. I'm sure that's something that has been spoken about before. So if you are getting on top of that inflammation and you're going into remission and everything's managed, then that's going to be the best thing for your bones. So discussions with your healthcare professional. And of course, as I'm sure you're also covering in other sessions, Claire, there are now many other options beyond steroids. So other treatments, which is great news. And I understand that some of the newer biologic treatments are actually being used for more moderate rheumatoid arthritis. So there really is the opportunity to perhaps not be on steroids in the way people were in the past. So healthy lifestyle, having bone checks and scans if you need them. And then thinking about this wider fracture risk assessment as you move into postmenopause as a woman, or you're over 50 as a man. Occasionally drugs might be necessary for younger people, particularly if there's continual rapid bone loss. So I hope there's something there that applies to you. And just finally, before we move on to the questions, quick mention of all the information that we have back at the Royal Osteoporosis Society. So lots of information on the condition, risk factors, scans and tests, bone health, drug treatments for bones, as well as living well with fractures, which I haven't covered, but I do know some people are really needing help with pain and symptom management. So lots there if you need it. We have a specialist helpline. We have support groups. We have a membership and regular email support for those who need it. So come to us if you need specific osteoporosis help. So I hope that's given you a good starting point. And I think, Claire, I'll stop sharing now. And Claire's going to take us into the questions.
Indeed. Thank you so much, Sarah. That was really, you covered a huge amount on there. And I'm delighted to say we've got quite a large audience watching us this evening. I've been having a little peek at something. And of course, one of the top questions that was asked ahead of this session was a little bit of an explanation about osteopenia.
Yes.
Is it a precursor to osteoporosis? Yeah. And again, a lot of you clearly explained the difference between osteoarthritis and osteoporosis, but for the layperson, it can be quite confusing, all those osteo. So could you explain a little bit about what osteopenia might be? I know that might be a whole topic on itself another day, but just top line.
Well, I think it's important to bear in mind what I said about the word osteoporosis. It really means the condition as a whole, and losing bone and the risk, the risk of losing bone strength and the risk of breaking bones. So it's got a wider meaning, but when we really focus on the bone density meaning, that's where the osteopenia bit comes up. So if your bone density is significantly lower than the average adult, they call it osteoporosis. If it's a bit less, not a bit lower than average, but not in the osteoporosis range, they call it osteopenia. So these are they're sort of terms about bone density. They're not a condition as such in themselves. I think it's important to understand that they're risk, a bit like blood pressure, I think, for something like stroke. They're really important markers of what's going on in the bone, but perhaps don't get too fixed on exactly where you're on the scale. So nothing changes particularly when you move from osteopenia to osteoporosis. And many of us, certainly as women, will have osteopenia once we pass the menopause. It becomes quite normal. So on its own, probably nothing to worry about.
And I'm just, one of the things that struck me was, over the age of 50, this should be something that should be being checked. I'm almost 59. This is your opportunity to go, surely not, you can't be 59, Claire. But yes, I am almost 59. And I've never been offered, you know, anything to do with my, you know, checking my bone density. So how would somebody request having a FRAX done, you know?
Well, I think there are, and it depends what country you're in. So certainly in England, NICE is the governing body, and there are very clear recommendations that you don't need to kind of come along and do a full assessment until someone's probably in their mid-60s. So there are kind of specific ages. But I think if you've got a condition like rheumatoid arthritis, then it's worth having that conversation. I don't think you have to rush off and book a scan or anything. It's more about looking at you as a whole. Mm-hmm. The reason to do this is to go on a bone strengthening medication. So one has to be aware that that's what it's all about. So if that's the way, you know, you need to think a little bit about that. But I think it's worth having that first conversation at some point, and they will look at you as a whole. But I think the good news is that many people are not having to it's when people were all on high dose steroids that I think it became much more urgent. I think if you're on high dose steroids, you break a bone easily, that's the time when you really need to get more of an urgent assessment.
Yeah, and I think you make an incredibly important point about the steroid use. And we fully understand that many of you watching here this evening might be on, you just struggle to really get off of steroids completely, but you can now probably understand why there is such a push to try and get people off of being reliant on steroids, because it does have such a knock-on impact. But low dose steroids is quite different. We're talking about really good high dose steroids, which I would hope that many of you won't be on. Great for bridging therapy when you're going through a massive flare or something, but then you know, it should be for a short term, as shorter term as possible. So let's get on to some of these brilliant questions that we had pre-submitted. So I'm just going to go straight into it. So this will be almost like quick fire round, Sarah. But so we've got somebody who has osteoporosis, and they may have to inject daily for 2 years, or maybe tablet or infusion. The thought of injecting is rather daunting. They've had RA for 35 years and lots of steroids. There you go, the steroids again. So what advice might you have for her that just the thought of injecting daily is a bit unnerving for them?
Well, I think, and I completely understand that, and I do know that some people feel very strongly about even having an infusion, or you know, they like the idea of a tablet. I think it's really important to discuss all the options with your healthcare professional, that may be your doctor, because there are a range of treatments. They are very much tailored to an individual. So, for instance, there is, I'm not sure which drug we're talking about, but the drug teriparatide, for instance, is very much targeted to people who've got a number of spinal fractures. They're at the more severe end, so they've got, you know, they've probably been on other things, and this is a really good treatment if you've got multiple spinal fractures, because it's what we call anabolic, and it builds bone. But I think you must have that conversation. If you are going to be having a treatment you do yourself, then there will be a kind of a support service in place, and it'll be properly explained to you. But nevertheless, voice your fears and look at the options would be my first suggestion.
And I think that's, you know, again, it's very much tailored to the individual. You know, it's not a one size fits all for everybody. You'll know that from your rheumatoid arthritis treatments. You'll all be on different things because we all react differently to and respond differently to different medications. So it's having that real open, honest conversation as to what will work best for you as individuals. So here's somebody, they're 63, they've had RA for 40 years, so a young person when they were diagnosed, and you know, quite high methotrexate for 23 years, osteoporosis for 6 years, 4 years on, I probably won't say half of these medications correctly, denosumab injections for osteoporosis. Is denosumab safe to take long term? again, you know, often people are worried about taking long-term medication, but of course the
I think
alternative.
all the treatments are generally safe long term, as a broad comment, and they are given. It's about balancing up risk and benefit a bit. There are a couple of kind of rare adverse effects, one of which is a sort of poorly healed area in the mouth when you have a tooth out, but it's very rare. We're talking about between 1 in 1,000, 1 in 10,000, and that usually the benefit you're going to get from the drug is going to be an awful, in terms of reducing your fracture risk, is going to be a whole lot less than this rare side effect. So you need to look at those. They will always be balancing these things up, but generally if you need it, then it's safe to carry on. We've got effectiveness research that goes on now up to 10 years with denosumab. The important thing with denosumab, I think that question might have asked about stopping it, is that you don't, it's one of few that you shouldn't stop suddenly. You usually need a follow-up treatment if you stop it, because it works so effectively that if you suddenly stop it, it kind of, the bone springs back into action perhaps, and you may then get more fractures for a while. So it's good and effective, but you need to use it in the right way and either stay on it or follow it up with something else. That would just be a quick point about denosumab.
And I think that that's a very good point on many medications, you know, you just stopping suddenly, and certainly, you know, we talked quite a bit about steroids already. There is no way that anybody should just stop taking steroids. It has to be well managed if you're to yes. wean yourself, and the same with many medications, because it's quite a shock to the body and it can have more detrimental impact. So if you're concerned about any of your medications, not just about your osteoporosis or RA drugs, do talk to your clinicians. Don't take it upon yourself to just stop, because that can have quite a detrimental effect.
Can I just say a quick thing there, Claire? And I absolutely agree with you on the steroids. I'm sorry, I should have said that, because as soon as you mention it as a risk factor, I should have said it. But I would just differentiate between denosumab and the other osteoporosis drugs, because sometimes people worry that they're a bit late with some of the other drugs. It doesn't matter too much with the other osteoporosis drugs, because interestingly, some of them actually hang around in the skeleton for quite a long time. So I would make that distinction. Denosumab, make sure you get the follow-up at the right time. The others, yes, of course, get them if you need them, but you don't need to worry like you do with steroids and denosumab. Is that okay? I just wanted to.
Yes, absolutely. Yes, yeah. And I think it just is, you know, again, making sure you're having those good conversations is vitally important. So we have a question here. Somebody's just been prescribed alendronic acid for osteoporosis in my spine. Is it advisable to start this as soon as possible? You know, they're kind of wondering, they're 62, can they delay it a little bit, or is it wise to start immediately?
Well, again, that goes back to what you were saying. It's all about your individual situation. If you're someone who's what we call high risk, and if you are someone who's had a recent, particularly a spinal fracture, it isn't good to wait too long. I mean, you haven't got to take it like today or tomorrow, but what we do know is that there's a kind of what we call an imminent risk. You're at more risk for the you know, during the next year or so. So if you've had one of those fractures, best to get on and get the treatment. However, there's often a conversation that needs to be had, because if in other situations where you've got risks like we've described, and it's all about kind of building up that picture and making a decision and weighing up what do you want and what's right for you now, because sometimes people with osteoporosis, so low bone density risks, the risk isn't high enough to need a treatment right now. So and you will need to discuss that and how you feel, and how you feel about getting a broken bone. All that needs to be discussed. So that's a bit of an individual one. I just think have that conversation again with your healthcare professional. Make sure you get what's right for you.
Yes, absolutely. Good thing. Quite a bit here. You know, we talked a little bit about the menopause, HRT, what part of, and so somebody's here asking about, does bioidentical hormone therapy help support osteoporosis along with other calcium counter supplements, so over-the-counter calcium supplements?
Okay, I think here we're talking about a kind of natural HRT. I'm just sort of, that's how people describe it. It's often described as bioidentical. So it's something that you wouldn't be getting particularly from your medical professional, but you may get it from someone who's interested in slightly more complementary approaches. The theory being that it's more like the normal hormones that we produce ourselves. So they give you a balance of different estrogens, and they give you certain sorts of progesterone. Now, all I can say really is that the medical world would say there are different, that these are kind of unregulated, so we don't know whether they're going to work as well as the standard HRTs that you get prescribed. They may do, but we can't be sure. There's no kind of regulation. So I think in the medical world they would say we really don't know if they're going to work like an HRT, and there's a little bit of caution in terms of, because some of the hormones you take to protect the lining of your womb, because that's something, and so we're not quite sure whether they're going to be doing that safely. So I'm being a little bit cautious there, and I would say I would a medical approach would not be to use the unregulated bioidentical hormones. Having said that, they are starting to use more natural types of progesterone in the standard HRTs. They are seen as being body identical, a bit more gentle in terms of side effect, and so something called micronized progesterone is one that you might get given. So that's all a little bit complex, Claire. We've got a fact sheet on HRT, so I would absolutely recommend whoever's asked the question to have a look, where we talk about bioidentical hormones, and we also point you to other sources of information if you need more. So
and again, just to reiterate, if you missed the link earlier, we do have a link to the website, ROS website on our website. So if you're not sure where to go, you can look at it at the useful links, but or call our helpline, and we'll certainly signpost you as well if you've missed any of that. But remember, you will be able to watch this back. We're recording this, and this will be available not only on Facebook but on our YouTube channel in a few days' time. So you will be able to watch this back if you want to go back and go, what did they say about that? And what was on that slide? Talking now about monitoring bones and scans and tests, somebody who's been taking oral prednisolone for around 5 years, a DEXA scan almost 3 years ago showed mild osteopenia. That was 3 years ago. How often should they go for another DEXA scan, or what is the sort of time period between, ideally?
I'd love to be able to give you nice, clear answers, Claire. I'm giving you very kind of not black and white answers. It will depend on the individual situation, because I think, as I said in my slide, if you've got very strong risk factors, so if you're going to be on regular steroids, or you've broken bones and you clearly got weaker bones, then they may not need to regularly scan you, because it's not going to change the decision about treatment. Remember that this scanning is used mainly to help target treatment and decide who needs it. But if they clearly know you need a treatment, they don't need a scan. So I think people feel naturally they would like to have regular scans, because they kind of want to know what's going on. But if it's not going to change the answer, and I wouldn't be saying that so much when I'm talking about some risk factors, but things like rheumatoid arthritis, steroid use, they are very strong risk factors, and particularly if you've broken bones. So don't be too surprised if they just say, look, at your age, you're now older, you've had the fractures, I just want you to stay on the treatment. But for many people, if they are using scanning, it would be probably every 3 to 5 years. It's certainly not worth having them every year or 2 years. There's not enough significant change to make a difference. People do love scans. We all want something that's going to give us that, they think the drug is going to be working, they need to see a change. But be reassured that the drugs have shown in the research that they reduce the chance of a broken bone, so they do strengthen bones. We know they do.
Exactly. And it wasn't absolutely clear whether this person has actually started any treatment yet. So I think, again, go back, have a conversation with their GP. Yes. And it may be that now is the good time to start. Somebody's talking here about REMS scans are becoming popular. Anecdotally, they seem to give more positive scores than DEXA. And do you expect them to be used more in the NHS?
A really interesting and very current question. If you go on any of the the sort of community chat rooms, there's a lot of discussion about REMS, so we get a lot of questions. It's a type of scan. It uses radio waves, it uses ultrasound, so it uses sound waves, and it is measuring what's going on in bones. So it certainly is really promising and interesting. There seems to be accuracy there, but I think it's still in the research field, would be my conclusion on that. And we don't know if it's reliable. We don't quite know yet. You need a lot of work on these kind of technologies to see if they're really sure. We don't exactly know whether what level indicates that you're at a higher risk of fracture, of broken bone. So we need more work. I don't know when and if. I mean, ultrasound in itself has been around measuring bones for decades, and we've never moved on far enough to see it as good enough as or as good as the DEXA scanning that we've got already. So I don't know the answer to that, but I think be a little bit cautious, because at the moment, again, these are not regulated by CQC. You've not got the same kind of assurance, and you don't really quite know when you go exactly how good the machine is. And so I think for interest, have it, but I think in the end you have to go with more of a kind of approach to fracture risk assessment and DEXA. Those are the ones that are currently best proven.
And I think that what's coming across, in this conversation that with Sarah this evening, and in previous conversations I've had with many clinicians and nurses over there, is research. There's always more research that we need. And I will put a little plug out there already that if you do get an opportunity to take part in some sort of research, if you're approached and you just think, oh, I don't know whether that's really for me, it's vitally important. So if you do have an opportunity and you are able to take part in some sort of a research study, do seriously consider it, because it will not only help you and be very fascinating for you as an individual, but will give us this sort of data. So in 5 years' time, in 10 years' time, we'll be having more of these conversations and going, yes, we now have the data that shows, the difference, or whether the REM scan is better than a DEXA, because we will have got that sort of study. So just a little plug there. If you ever get the opportunity, do seriously consider it. We need more and more lay people, patients, to get involved in research. Moving on now about symptoms and what to expect with fractures. Having RA, steroids, and not recent, but diagnosed with osteopenia 3 years ago, are there any symptoms to really look out for that it could be osteoporosis? I mean, you were saying earlier in your presentation that some of the symptoms can be very similar with the pain. So what are
Well, as I say, you only get symptoms if you've broken a bone. So we're often talking about these spinal fractures. So I guess if you break a bone easily, that's the first sign. So if you stumble inside, put your hand out and your wrist breaks, you think, well, that's not something you would expect to happen. So falling from a standing height is often what we say. But if you've had one of these spinal fractures, again, they're very varied. I mean, some people don't get any symptoms at all. They don't get any pain at all. They might notice they're getting a lot shorter. They might notice that their clothes are not fitting quite so well, that they've got less space between their shoulder and their waist, and they notice changes. So you might notice a bit of difference in your height, but it might not be that. It might be something else like arthritis. But I think if you are having back pain and you've noticed some change in your height, and if you've got these other risk factors, so if you are very slim, you've got rheumatoid arthritis, you've been on steroids, those are the kinds of things. But you don't get any symptoms unless you've got a fracture. As I say, you don't, it's not creeping around in your bones causing pain. And sometimes people do think that the pain they're getting in their joints is to do with osteoporosis. It's much more likely to be osteoarthritis.
Thank you. You've just given me a reason not to lose too much lose weight. I'm definitely not slim, so that might be helping me. But of course, joking aside, weight management must be really important on your bone strength, you know,
Yeah,
the pressure you're
absolutely.
putting through your joints and on your bones.
And be right, be appropriate. You know, if you're
Yes.
too heavy, then that's not good. That's putting too much stress on your ankles and so on. But we would never recommend being overweight. But there are some people who are underweight, and therefore not only is there not the same pull on the skeleton, but you haven't got any padding if you fall, to be honest. And interestingly, we produce a sort of estrogen in our fatty layer post-menopause. So not advocating being overweight, I'm just saying be a little bit aware that you may be a
Good
bit
healthy weight.
underweight. Yeah.
And just again, for information on nutrition, etc., we do have well-being course on nutrition, and we have a well-being course on exercise, different types of exercises. Now, it was something I made a note of when you were giving your presentation about the importance of exercise, but resistance and strengthening exercise you would recommend as well, but also about the balance. So things like Tai Chi,
Yeah,
and Pilates, are they the sorts of things, or yoga, would they be the sort of things that you would?
yes. I think some of you may even know that we did a project a few years ago called Strong, Straight and Steady. So there are strong, steady and straight. So there are different ways that exercise can help. It can help to promote bone strength. So that's where and not everyone can be doing impact exercise. Not everyone can be jogging and doing that kind of work, but if you can, that has a particular benefit. Alongside that, yes, absolutely, building on muscles and working them quite hard. So if you're lucky enough to be able to do that, and I very much appreciate not everyone can, but that would be the optimum, is those two, both of those two. But yes, absolutely, work on balance, work on back muscle strength, because that supports your spine. So if you get a fracture or you're moving and lifting, if you've got good support to your spine, then that's going to help as well. So yeah, lots of ways exercise can help. And again, we've got videos and we've got fact sheets on our website that look very much at exercise for bone. But I would say anything's better than nothing. So please don't feel, if you're someone who is quite limited, you know, even if it's standing up every hour and when you're watching the television, and even that's better than being immobile. So fine.
Absolutely. And you know, just keeping that little bit of gentle movement and range of movement is always good. And again, that we've got videos on our website, and there's simple exercise. You don't have to go to a gym, and you don't have to get into your lycra with your sweatbands on. You know, it's things that you can do while you're waiting for the kettle to boil. You know, just leg lifts or something like that, or sitting watching Coronation Street, lifting some, you know, have a tin of baked beans or something that you're lifting in a seated position. There is something for everybody, and something is certainly better than doing nothing. So,
just a word, you asked about Pilates, Claire, and yoga, and these things are certainly very useful. Tai Chi, very useful for balance, and Pilates and yoga can be very useful for, beyond all the kind of well-being and so on, can be very useful for muscle strength and keeping you fit. And probably need to add some other things in if you can, but they're, you know, they've got a really important part to play.
Yeah, we touched a little bit there on nutrition, on a little message that's just caught my eye in the chat. Is about, you know, we hear, you know, calcium is good for your bones, etc. But of course, a lot of people find that going dairy free actually does help with some of their gut problems, but also their inflammatory markers as well. So again, it's different strokes for different folks. You know, what works for one doesn't work for another necessarily. But if somebody is cutting dairy out of their diet, then should they be perhaps taking some other supplements to get that calcium that they might need?
I think the important thing, as you say, is making sure you get enough. It really doesn't matter how you get your calcium. We tend to talk about dairy just because it's a big part of the Western diet and it's easy and it's inexpensive and so on, but it's not absolutely essential. So you just need to take extra care. So, and it's really more people transitioning over to a new diet. If you're going to eliminate any food, you need to replace it. So you need to have dark green leaf vegetables. You need to perhaps have something like tofu or something which is synthesized with calcium. So, and if you can't get that, then calcium supplements. We'd say go for diet first because you get all the nutrients you need. But if you can't do that, there are calcium supplements you can choose.
And again, you talked in your presentation when we're talking about supplements, vitamin D. Again, you know, great if you can get out in the daylight most days. You don't. That doesn't mean sort of lying out in the sunshine, sunbathing, because of course you've got to be careful to protect your skin as well, but just getting enough daylight or taking supplement for vitamin D's.
Yeah, absolutely. It's in the summer months, so April through to September you're going to be getting sunlight. You're getting vitamin D from sunlight, and as you say, just out 10 minutes morning, afternoon. You don't have to get burnt, but there is a concern, and there has been, with people being locked down, that people are not perhaps getting out in the way they were. So you need to not be behind the glass, but you can be on a veranda or a open window. You haven't got to be outside, but being outside gives you the opportunity to be active at the same time.
Yes.
And supplements, particularly you might want to consider a supplement, particularly in the winter, or if you're someone at risk of vitamin D insufficiency.
There were lots of questions about steroids, but I think we've covered quite probably most of that in that. We've covered the bit about exercise, and we talked about hormones, etc. as well. So one thing, we have quite a lot of people who are diagnosed as children with JIA and then carry it on into adulthood. Are people that have lived with juvenile idiopathic arthritis at higher risk because of the length of time of the disease? Or
I think, again, that goes back to what we were saying before, that yes, if you've been on steroids for a long time, yes, if you've had unmanaged inflammatory condition for a long time, yes, you might be more at risk. But the good news is that I understand that things should be very well managed, and so they're going to get on top of it as soon as they can. The inflammation, you're going to get appropriate treatments that are not going to be steroids. So I don't think anything's inevitable. The important thing is to manage the condition, the rheumatoid arthritis, and then hopefully you will be reducing your risk later on. So yes and no, I'm afraid, once again.
So I hope we've given you lots of food for thought there on the topic. You will be able to watch this back. Thank you ever so much. We do our Facebook Lives generally, not hard and fast, but generally the last Wednesday of every month. So do watch out on Facebook for the next one. Can't remember what the topic is off the top of my head, but I'm sure it'll be fascinating in August. Thank you so much. If you want more information about osteoporosis, we will have the link, and the link is in the chat I just saw there a moment ago on Facebook, but we will make sure that you can see that through our website. Sarah, thank you so much for joining us this evening. I've learnt a lot. I did have a little quick glance down, and you're all very sweet saying I don't look like I'm 58, but believe me, I feel it. So you're very kind, and I think you're just flattering me out there, but thank you so much. It's been really fascinating. Thank you again. Thank you all for joining us. We had over 70 people at one stage. People will watch this back, as I said, Sarah, so it's obviously a very important topic, and I really appreciate it. Just as closing, for those of you who had lots of questions about different medications, about your RA, that wasn't the topic we were covering today, but please do phone our helpline. It's free. We have a free medicines booklet as well, and I'll give a little plug to our very recent booklet that we brought out called Blood Matters, which is all about blood monitoring and what are all those blood tests for, or what are they looking at. So again, that's freely available. Do give us a call, drop us an email, inquiries@nras.org.uk. As I say, give us a call, and stay in touch. Keep following us on Facebook. Share this with your friends if you know anybody who'd be interested. And I thank you very much for joining us this evening. And thank you, Sarah, for your expertise and a really, really fascinating conversation about osteoporosis.
Thank you. Thanks for asking me. Really enjoyed it. Thank you. And
thank you very much. Good night.
Bye-bye.